So it's sharp 4. So can we start? Sir, you're in mute.
Okay.
We are beginning with the session. Good afternoon, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. And he is none other than Professor Dr. Kamlesh Tiwari, sir. Sir is FRCP, Glasgow, FRCP, Edinburgh, FACP, USA, FICP, FIACM, FIAMS, Director at Narayan Hospital and Maternity Center, Dhodpur, Koti. With the help of sir, we'll be taking a close look on today's topic, which is subclinical hypothyroidism. Before moving on to today's session, let us have a brief look on what the topic says. Normal levels of thyroxine and increased levels of thyroid-stimulating hormone are typical signs of subclinical hypothyroidism. It is observed in 3 to 15% of people, and the fact that each person's hypothalamic pituitary axis has a different personal set point in the secondary cause of the little intra-individual variance in TSH levels. Subclinical hypothyroidism is associated with a higher risk of fatal and non-fatal coronary artery disease events, congestive heart failure, and fatal stroke. We'll be learning more about subclinical hypothyroidism with sir. So now moving on to today's session, I would like to welcome sir at our platform and would like to hand over the session to him for his talk to begin. Sir, over to you.
Thank you, Batul. Thank you very much. You have told many things about subclinical hypothyroidism. I have chosen this topic because most of the general practitioners do some mistakes in the treatment of subclinical hypothyroidism. Reason I will tell you later. As we know, there are two main hormones of thyroid, thyroxine and triiodothyronine, that is T4 and T3. And it is formed, plasma iodide is taken up by the colloid and comes into the follicle. This iodine combines with tyrosine and two molecules of diiodotyrosine and one molecule of diiodotyrosine. So two molecule and one molecule makes triiodothyronine, and two molecules of DIT makes 4 units, thyroxine. That is thyroxine. Thyroid gland is gland of hypothalamic pituitary thyroid axis, control of hormone excreted by classical negative feedback mechanism. Thyroid releasing hormone from hypothalamus stimulates TSH from pituitary, which stimulates thyroid hormone release, that is T3 and T4. What is normal TSH level? Actually, normal TSH level is 0.35 to 5. Optimal is 1.8 to 3 only. So this is the diagram showing if it is from 0 to 0.4, that is hyperactive thyroid. But from 0.4 to 5, that is normal thyroid function. And 5 onward to 10, that is hypothyroid. So what is subclinical hypothyroid? Subclinical hypothyroidism is defined as serum thyroid stimulating level above the upper limit of normal. So TSH is high despite normal level of free thyroxine for a given population reference. And overt hypothyroidism is defined as serum thyroid stimulating hormone level above the upper limit of normal with decreased level of serum free thyroxine for a given population reference. So subclinical hypothyroid, TSH is high and T4 and T3 is normal. And most of the physicians looking at the high TSH start treatment then and there. A spectrum of thyroid disease, that is overt hypothyroidism, subclinical hypothyroidism, euthyroid, subclinical hyperthyroid, overt hypothyroid, and thyroid hormone resistance. Subclinical hypothyroidism or mild thyroid failure is a common problem with a prevalence of 3 to 8% in the population without known thyroid disease. And the prevalence increases with age and is higher in women after the 6th decade of life. The prevalence in men approaches that of women with a combined prevalence of 10%. So it is not that common. Risk factors: family history of thyroid disease, personal history of thyroid disease, presence of anti-thyroid antibody, radiation treatment to head, neck, and chest, other autoimmune disease, medications like lithium, amiodarone, and iodine, and old age. So these are the risk factors. And causes are autoimmune thyroiditis. That is the most common cause. That is Hashimoto thyroiditis. And another is treated gas disease in the form of radioactive iodine therapy or subtotal thyroidectomy or antithyroid drugs, head and neck surgery, and radiation in the head and neck area. So these are the common causes for subclinical hypothyroidism. So what is the course? In some cases, the TSH level will be normal if measured again several months later. We would then attribute initial elevation to laboratory error or perhaps to episode of silent thyroiditis with a transient hypothyroid phase. So what happens if TSH is high in the beginning? It comes down to the normal after some time. So that is a transient thing, maybe laboratory error or maybe silent thyroiditis. So nothing to worry in that case. In other cases, the subclinical hypothyroid remains unchanged and does not progress. So it is a static. Patients with subclinical hypothyroid have a high rate of progression to clinically overt hypothyroidism, that is 2.6% each year if antibody are absent and 4.3% if antibody is present. In a study in men and women older than 55 years with a mean follow-up of 32 months, the TSH level normalizes in 52% of those with serum TSH of less than 10 ml per unit. So most of the time it comes to the normal. So natural history of disease is progression to euthyroid state, to subclinical hypothyroidism, and to overt hypothyroidism depending upon serum TSH level and antithyroid antibody. Clinical diagnosis: symptom of hypothyroidism manifests when the disease is fully developed. But even in the earliest stage, that is subclinical stage, one or more of these findings may occur. And these findings are dry skin, cold intolerance, and easy fatigability. These are significant and more common in a patient with raised TSH level. And these symptoms improve after treatment with thyroid hormone. Some patients with subclinical hypothyroidism do indeed have clinical manifestations of mild thyroid failure in relation to their serum TSH level. Progression to overt disease can manifest with menorrhagia, neck swelling, delayed relaxation of deep tendon reflexes, and bradycardia. So these are the signs and symptoms of hypothyroidism. I think you all know. What is the laboratory diagnosis? Patients with subclinical hypothyroidism can be categorized into those with mildly elevated TSH, that is in between 4.5 to 10 ml, and with a markedly increased serum TSH level, that is more than 10, along with free T4, T3 level within the reference range for the population. Elevated serum TSH on two separate occasions, 6 months apart, that is required for diagnosis. Presence of antithyroid antibody, neck swelling in the ultrasound, and thyroid scan with radioactive iodine. So these are the diagnoses which we do. So what may be the adverse effect of this subclinical hypothyroidism? One thing, progression to overt hypothyroidism with systemic manifestation of disease leading to thyroid failure. That is common. Patient may go into thyroid failure. Second is increased risk of metabolic syndrome. Third is cardiac dysfunction, neuromuscular dysfunction, psychiatric and cognitive dysfunction in the form of depression, bipolar disorder, adverse fetal effect, and SHH and pregnancy. So these are the proposed adverse consequences of subclinical hypothyroidism. So we'll take one by one. Progression to overt hypothyroidism patient may become normal. So we will say that, well, it may be a lab error or it may be mild hypothyroiditis which has subsided, or patient may go into overt hypothyroidism, and in overt hypothyroidism, antibody may be positive, so it is 4.3% if it is positive, and if it is negative, 2.6% patient goes every year. A TSS level greater than 10 ml predicts a higher rate of progression. We will take one by one. Increased risk of metabolic syndrome. There are few evidences that treatment improves lipid level in subclinical hypothyroid, but the possibility that lipid level will improve with levothyroxine therapy is fair if serum TSS level is greater than 10, and questionable if the TSS level is less than 10. Less than 10 is a questionable thing. Cardiac endpoint adverse effect. The cross-sectional Rotherham study showed an association of subclinical hypothyroidism with myocardial infarction and aortic calcification. In contrast, the Beckenham study showed no increased cardiac mortality in a 20-year follow-up. So these are two contradictory things. So there were several trials in between, and meta-analysis suggests that a cardiovascular risk exists for a person younger than 70 years, with no effect for those aged 70 to 80 years, and possibly protective effect for those older than 80 years. Thus, the cardiovascular risk issue remains controversial, and a large study is needed. Cardiac dysfunction. Some studies have shown improvement in cardiac contractility and systolic time interval with the levothyroxine therapy. No evidence exists to support an association between heart failure and the serum TSS level of less than 10. Again, most studies were not categorized for degree of TSS elevation, and data remains insufficient for a TSS level less than 10 ml per unit, but strongly suggest for a TSS level greater than 10 ml per unit. Neuromuscular dysfunction. It has been suggested that neuromuscular symptoms and dysfunction are common in patients with SCH and can be reversed by levothyroxine treatment. A definitive answer will require more study with TSS level stratified as less than or greater than 10 ml per unit per liter. Psychiatric and cognitive dysfunction. Data related to aggravation of depression, bipolar disorder, and effect on cognitive function have been presented. A recent study showed no association with anxiety, depression, or cognitive dysfunction. Nonetheless, it is still reasonable to have a low threshold for therapy for SSH in patients with depression, bipolar disorder, and cognitive dysfunction. So summary is that for metabolic functions, cardiovascular functions, neurological functions, and psychiatric functions, there is no convincing evidence that treatment is beneficial if serum TSS is below 10. If it is more than 10, it may be helpful, or it will be helpful. What about pregnancy? As we know, the prevalence of hypothyroidism during pregnancy is a bit higher. It is 11% in India, and in first trimester, 13.5, and antibody 18.5. Well, why it is high? Because TSS level is low in cases of pregnancy as compared to the normal population. See the TSS level. Normal non-pregnant lady 0.3 to 4.3, but in first trimester it is 2.5 is highest, and second trimester and third trimester 3 is highest. But in normal it goes more than 4 or around 5. So because TSS is low, increase in the chances of subclinical hypothyroidism is more in pregnancy. A seminal study by Haddock et al. Showed 7-point reduction in intelligence quotient in the children aged 7 to 9 years whose mother had subclinical hypothyroid at pregnancy, compared with the children of euthyroid mothers. Although this was a single study, it nevertheless points to the need of screening of pregnant women and therapy for mild thyroid failure in women who are pregnant or planning to become pregnant. Subclinical hypothyroidism in pregnancy, it is associated with multiple adverse outcomes in the mother and fetus, including a spontaneous abortion, preeclampsia, gestational hypertension, gestational diabetes, preterm delivery, and decreased intelligence quotient in the offspring. Recent study society guidelines also suggest lower level of TSH as a normal range in pregnancy, especially first trimester, and second and third trimester, as I have told you already. Adequate levothyroxine replacement in early pregnancy with subclinical hypothyroidism can reduce chances of preterm delivery, but there is no conclusive evidence of reduced chances of another fetal or maternal complication with the therapy. The Indian guidelines is still not clear about treating women with TSH between 2.5 and 4.5 ml. But Indian Thyroid Society guidelines have suggested that universal screening for thyroid profile during pregnancy at the first antenatal visit should be the choice and should be the norm. So in summary, subclinical hypothyroidism in pregnancy is common. Subclinical hypothyroidism may be associated with adverse pregnancy outcome. Universal screening for subclinical hypothyroidism should not be done in pregnancy. Pregnant women with subclinical hypothyroidism and thyroid peroxidase antibody require thyroid replacement therapy. Most patients with subclinical hypothyroidism in pregnancy will not require treatment in postpartum period. So what should be the criteria for treatment? According to research from 2009, evidence is mostly inconclusive, and those with TSH level between 5.1 and 10 will benefit from treatment. In deciding whether or not to treat, we will take into the consideration things like TSH level, antithyroid antibody, symptoms, and how much they are affecting the life, age of the patient, and medical history. Management of subclinical hypothyroidism differs depending upon whether the serum TSH concentration is between 5 to 10 or higher than 10. Most thyroidologists agree that all patients with subclinical hypothyroid and the serum TSH level above 10 should be treated with levothyroxine. A study has shown that levothyroxine therapy results in 8 milligram reduction in low-density lipoprotein level. Levothyroxine therapy has been also shown to reduce neuromuscular dysfunction, psychiatric, and cognitive dysfunction. For all patients with SSH and a serum TSH concentration above 10, in whom individualized decision for therapy is made, they should be started with levothyroxine, and dose should be 1.5 microgram per kg body weight, and dose should be titrated according to the patient age, serum TSH level, and serum 3-thyroxine level. In older patients with cardiac comorbidity, levothyroxine should be started in a minimal dose, like 25 microgram or 50 microgram. And thyroid profile should be checked every 8 weeks. Once a normal TSH level is achieved, it should be checked every 6 months thereafter. So I have told that it is not beneficial between 4.5 to 10. So who should be treated then? TSH level of 4.5 to 10, some patients may require treatment, and the patients are pregnancy or intention of pregnant lady, goiter, therapeutic trial for possible hypothyroid symptoms if it is there, childhood and adolescence, TSH level more than 4.5 on 2 separate occasions, bipolar disorders, depression, infertility, presence of antithyroid antibody, progressive TSH increase, and ovulatory dysfunction. So these patients should be treated if TSH is below 10 as well. So management is elevated serum TSH level, confirm and check free thyroxine, antibody, and lipid level. If TSH is more than 10, treatment is must. If it is less than 10, divide into two parts, whether it is antibody positive or antibody negative. If it is positive, consider treatment. If it is negative, again, symptoms, important symptoms like goiter, increased lipid, young patient, middle-aged patient, pregnant patient, and evolution in the lady should be treated. Consider treatment. And elderly patient with no symptom, no goiter, no increased lipid, not pregnant, just keep an eye and close follow-up is needed. Treatment is not needed, just close follow-up. In elderly, what we'll do in elderly? Well, as I've told you that if serum TSH is more than 10, it should be treated. But that is not the case with elderly cases. Consider treatment. If clear symptom of hypothyroidism is there, then we can start treatment in the older patient more than 80 years age. If there is no symptom and TSH is high, like 15 or 16 or something like that, don't treat. And consideration in children, yes, children with TSH level higher than 10, irrespective of its cause, must be treated. Children with subclinical hypothyroidism, TSH level between 4.5 and 10, if they have got goiter, if sign and symptom of hypothyroidism is there, if increased risk of progression into overt hypothyroidism is there, Hashimoto's thyroiditis is there, syndromic children, and genetic etiology, these patients should be treated. Children should be treated. The conclusion is, it is a common in females, increased risk of frank hypothyroid, lipid abnormality, cardiac complications, psychiatric problem, and troublesome pregnancy have been observed, but there is no conclusive support for treatment if TSH is between 4.5 to 10. It should be treated if TSH is more than 10. Should be treated in frank symptoms. Because of the conflicting study, there is still a lot of debate about how and if subclinical hypothyroidism should be treated. The best approach is an individual decision. So take home message, do not treat all cases of subclinical hypothyroidism. Think twice before starting treatment if TSH is between 4.5 and 10. Thank you. Thank you very much.
Thank you so much, sir, for your comprehensive talk and for such a wonderful presentation that you have shared with us. We have few questions, sir. The first question is, why TSH is high in subclinical hypothyroidism?
Pardon, why?
Why TSH is high in subclinical hypothyroidism?
TSH is high.
Yes.
Well, because sometimes there is Hashimoto's thyroiditis or autoimmune thyroiditis for a shorter period. So in that case, TSH may go high. In other autoimmune disease, it can be associated and can be high. So, or if there is mild degree of thyroid failure, it can be high. So these are the conditions in which TSH can be high. In normal thyroid, it is not high. There is some problem, maybe mild, maybe very mild, but there may be some problem.
Thank you so much, sir, for answering this question. We'll move to the next question that we have received. And this question is,
Yes.
which abnormalities on CBC count are associated with subclinical hypothyroidism?
See, can you repeat?
The question is, which abnormalities on CBC count are associated with subclinical hypothyroidism?
Well, in generally hypothyroidism, MCV is a bit high. It can be high little bit, but I'm not sure. MCV should be high in CBC count. Main hospital volume of red blood cell.
Thank you, sir, for answering this question. We'll move to the next question and the last question for today's session. The question is, what are the most common causes of hypothyroidism? And is there a link between vitamin D levels and autoimmune thyroid disease?
Yes, autoimmune thyroid disease is the most common cause for hypothyroidism. And direct link of vitamin D, well, vitamin D is a very vast thing. Everywhere you can attach vitamin D, but there is no such link between thyroid and vitamin D. Vitamin D is associated with many diseases, not directly, but indirectly, yes, you can say, because in India, if we measure vitamin D, most of the patients are vitamin D deficient. I don't know, I can't explain the cause, because country like India having sunshine, this and that, and vitamin D is low. Reason is not known, but they are explaining that maybe persons are not going into the sunlight, that's why they are vitamin D deficient. But I can't think, no. Even a slight sunshine can give sufficient amount of vitamin D to every Indian. Still, Indian people are deficient in vitamin D. I can't explain the cause.
Thank you so much, sir, for answering all the questions. And I would also like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful insights upon the topic. Thank you so much, sir, for your valuable time.
Thank you.
So we are closing the session here for today, sir. Thank you.